we are very excited to have Dr. Daphne Voineskos join us for this presentation on medications in focus, navigating depression treatment. So I'll just start by introducing Dr. Voineskos. She currently holds roles as the scientific director and psychiatrist in the Poul Hansen Family Center for Depression, medical lead of the rTMS clinic, and clinician-investigator with the Krembil Research Institute here at UHN. Additionally, she is an assistant professor at the University of Toronto. Her research is recognized locally, nationally, and internationally, and is focused on the neurobiological mechanisms of treatment-resistant depression, with a translation goal of integrating these scientific findings into clinical care. Thank you for joining us this morning, Dr. Voineskos.
Thank you so much for having me, and welcome everybody. I think I say this every time, but it's always very odd to hear yourself introduced by other people, and it's a little bit awkward sometimes, but that's okay. So I'm going to share some slides today. I know that there are many treatments for depression. We've just heard a lot about wonderful psychotherapies that we offer within our center, and our focus now will be a little bit more on medications and some other treatments as well. So let me just sort this out here. I'm going to share my screen. And now, great. So I hope you can all see the actual slides and not my presenter view. But if that's not the case, please let me know, and we'll go forward. So I always give a little bit of disclosures. I do have some research support and some support from the university, but no interest or financial investments at all in any scientific or treatment modalities or companies. We'll talk a bit about our objectives for this sort of quick half-hour presentation. We're going to talk about different types of depression and then different types of treatment for each type. We'll talk a bit about some of the evidence for different medications for major depressive disorder. We'll also focus on something called treatment-resistant depression, which has multiple names, and we'll talk about those as well. And then we can also talk a little bit about some of the novel or on-the-horizon types of treatment for depression and major depressive episodes. So I've pulled all this information from a lot of our guidelines that exist around the world. There are multiple guidelines for the treatment of depression. We have Canadian guidelines, which are called the CANMAC guidelines. The last ones for major depressive disorder were published in 2016, and I'm on the committee for the update, which is coming out. It's called the 2023 update, but it will be published in the next few months. There are also bipolar depression guidelines from the CANMAC group, the American Psychiatric Association, a group called NICE, which is from the UK, and the RANZAP, which is from Australia and New Zealand. So lots of different guidelines from around the world that seem to have a lot of overlaps, some differences, and we'll talk a bit through those. So we heard from our previous presenters about how we define depression. We'll talk from a more clinical diagnostic perspective here in terms of how, as psychiatrists, we would look at the criteria that would meet our sort of thresholds for a major depressive episode. So you have to have at least one of these two things. At least for the last 2 weeks, we look for somebody who has low mood most of the day, nearly every day, and diminished interest or pleasure, what we call anhedonia, in almost all of your activities. And then you can have some of the next several things. So changes in sleep, we heard about that, whether people either are sleeping too much or too little, lower levels of energy, changes in your weight or appetite, either up or down, changes in your attention or concentration, and really having difficulty there. What we call psychomotor retardation or agitation, which is a fancy way to say you feel and people around you have noticed that you seem quite slowed down. People talk about being in a fog or like they're moving through mud, or the opposite, what we call psychomotor agitation, where people feel as though they're really sped up. It's hard to sit still. You could be quite fidgety, and to the point where the people around you also notice these changes. And then these big ones, including feelings of worthlessness, guilt, or hopelessness, and thoughts or images of death or dying by suicide. All of these make up sort of the picture of what we call a clinical major depressive episode, and it's very difficult, obviously, for people to experience these. So we'll talk a little bit about different types of depression. The one we see the most often and that we have the most treatments for and has been researched the most is called major depressive disorder. Major depressive disorder is when people have these episodes of depression, the criteria that we talked about, that last for at least 2 weeks consistently at a time. And usually either one episode like that or multiple episodes with feeling well in between those periods of depression. So how do we know who should receive medications versus other types of treatment for major depressive disorder and these major depressive episodes? What we know from the research that has been done and multiple different studies that have been pooled together to show evidence is that, excuse me, antidepressant medications do show good evidence for treating the majority of these types of episodes. For people who are what we call moderately or severely unwell, certainly an antidepressant medication or multiple is the way to go. For people who have more of a moderate major depressive episode or mild major depressive episode, things like behavioral activation, self-management, and the amazing psychological treatments we just heard about are more evidence-based. But we always consider when talking about medications with our patients or about treatment options with our patients, what patients would like to do. Would they like to have a medication? Would they prefer to not? Have medications worked? Should we look at other what we call non-pharmacological interventions? And what has worked for people in the past if they've previously been depressed? And that can usually guide our treatment options. So this is an algorithm from our treatment guidelines of how to choose an antidepressant. So we talk about and think about whether people are on other medications for potentially physical or psychiatric illnesses, whether there are particular side effects that potentially they've experienced before that we would want to certainly avoid, and which medications are generally more tolerable. And then we look at what we call our first line antidepressants, which is a complicated table and we won't really go through that. But again, here are some other things to consider, and those are things like other illnesses that people may have, what people prefer, side effects and responses to previous antidepressant options, and what symptoms exactly people are having. So perhaps if somebody is having difficulty sleeping, we may decide to prescribe with our patient's consent a medication that we give at nighttime that can help make people a little bit more sleepy to hopefully resolve that particular issue. We also then consider factors of the medications themselves. Which medications work or work more often? Which medications are more tolerable than others? What could interact with other drugs or medications? How easy is it to use? And we know that taking medications as a whole is difficult. So if we can prescribe something that's once a day versus 3 times a day or 4 times a day, even sometimes twice a day, it's much more likely that people will take the medication. If you don't take the medication and it's going to work for you, it's not going to work for you, right? And then, of course, we always want to consider cost and availability for people. So there's no point in prescribing medication that we can't find at a pharmacy or that is out of stock in most places because of some backup at the factory where it's made, or something that's very new and very expensive and not covered by people's insurance if they even have it. So here's that table I was talking about. We're not going to go through this you will have if you are able to access the slides that are available on the website afterwards, so you can see what we describe as our first line antidepressant medications. So what about side effects? This is a big topic and a common question that we get and something that comes up over and over again, and of course is a big concern. So how do we know which medication has the fewest side effects? And I think that may actually not be the right question, because most medications in most fields of medicine have some side effects. Eye drops, medications for gastrointestinal problems, even things like Tylenol and Advil that are not prescribed and are available over the counter have side effects. So what we need to look at, hopefully, is which side effects people are more likely to or less likely to experience, which side effects will bother or not bother the majority of people, and which side effects potentially we could use to our advantage. For example, if somebody is sleeping too much, maybe we'll look at prescribing medication that is is not sedating, that does not make people sleepy and could help to activate them, give them a little bit more energy. If somebody has a cardiac diagnosis, a problem with their heart or their blood pressure, perhaps we'll look at medications that have fewer cardiac side effects or less effect on the cardiovascular system. Weight gain can be a big problem in a lot of people, no matter what illness or part of life they're in. And so we would usually want to look for medications that have less weight gain. And of course, sexual dysfunction could be a big problem with antidepressants. Many people have experienced this, and so keeping this in mind for people of all ages is really important. Just because somebody is in what we call later life depression does not mean that their sexual activity is less important than someone who is younger. There are also serious side effects that we need to consider. And again, these are things like problems with the rhythm of the heart, risks of changes in blood pressure that could potentially contribute to falls or unsteady gait. This big word here, hyponatremia, has to do with the levels of sodium in your blood. So people who have changes in how their kidneys function, people who have risks of bleeds in their digestive system, and people who have changes in how their liver function. So these are all things that we need to consider when we're prescribing medications. And now this is probably the second most common question. I don't mind getting this question from my patients because it usually means that people are doing well. And that's what we like to see, right? We really like to see our patients doing well. We like to see people, a lot of times when we're sort of wrapping things up, I say, I hope we don't see you again. I'd love to see you, but I hope we don't see you again because it means that you're doing well, but we're here if we need you. And so talking about this and the recommendations for when or if people should or can stop their antidepressant medication is really important. And I think it's a huge part of the discussions towards the end of what we call our episode of care when we're helping people to feel better. So there are certain scenarios where people should stay on their medications for the foreseeable future. That firstly are people who anytime we sort of shift medications or change things or without treatment, they frequently have these recurrent prominent episodes of depression. People who have really severe episodes where they have issues like thoughts of ending their life, or they cannot work or be in school or be functional parts of their family if they are depressed. People who have what we call depression with psychotic features, and we'll talk about that in a little bit. People who have long-standing or chronic episodes of depression, and people who have sometimes other illnesses in the psychiatric or the physical health realm. And also people who meet the criteria for what we call treatment-resistant or difficult to treat depression and have these episodes that have taken a really long time and multiple trials of medication and therapy to find a combination of things that works. I think it's important for people to understand what happens sometimes when medications are stopped. And so this is a study from the New England Journal of Medicine, which is one of our biggest, most prominent journals in medicine and in academic science, looking at many people who stopped their antidepressant medication while being followed by their family doctor or their GP. And so we have this little graph here. This is called a Kaplan-Meier survival curve, if anybody has seen it before. And we have two lines. So the red line are people who stopped their medication. The blue line are people who continued their medication, their antidepressants specifically, even though they were feeling well. At the bottom here, we have the number of weeks that people were on medications. It goes up to a year, 52. And on the left, you see how likely it is that people will remain well. And so to orient you a little bit, closer to 1 means they're likely to remain well. Closer to 0 means they're likely to become unwell again. And so you can see here that at the 6-week mark is really when things start to separate. So for the first 6 weeks after stopping, the people in red who stopped their medication, people were generally doing pretty well. Most of the people did not start to have any symptoms of depression that would qualify for a depressive episode again. But the separation comes at this 6-week mark, so just over a month. And some people who are in attendance here today, this may resonate with you. It certainly resonates with me, seeing this with patients who we've tried to stop their medication in this sort of time period. Now, this is not to say that everybody should stay on their medications. We'll talk about that in a moment, but this is just a study of people, a large group of people looking at it. And the big separation then comes at this 26-week mark, so about that 6-month mark, where people really, some people also who were taking medication, maintenance medication, also started to become unwell again. And that's because of the cyclical nature of major depressive disorder that is recurrent. The people who stopped their medication in this study, again, specifically, this is where another big dip happened. So that's just food for thought. Again, it does not mean that you have to, anybody here or anybody with depression has to continue their medications forever. And the other piece that's really important when we talk about this is what happens, what side effects and symptoms happens when people stop their medication. And big side effects and problems can happen when people stop their medications abruptly. ADTs here mean antidepressant treatments. Usually they're mild, although they don't necessarily feel mild when you stop medications abruptly. People have things like flu-like symptoms, insomnia or difficulty sleeping, nausea and GI problems, sensory disturbances. Sometimes people talk about feeling zaps in their brain, or seeing flashes of light, feeling their nerves firing in their arms and legs, and also sort of within their brain, and really feeling on edge, what we call hyperarousal. And so usually what we recommend for people is that it's okay in the most times to try and stop medications when people are feeling well and have been well for a period of time, but we should do this work together, right? So we should slowly taper down the dose of medications over several weeks to try and avoid these really unpleasant experiences. So what do we do now if the antidepressants aren't working, the first one or the second one we tried? What happens next? So there are lots of options. The first option is either to wait and see if things get better. Maybe there was a blip, maybe there was something stressful going on in life, or some physical change. And then we also think about when to switch medications. So if somebody, after 2 to 4 weeks of trying a medication, is not getting better, we can increase the dose. If they're having side effects, we can look at switching the medication. But there isn't really a ton of evidence to support what we call an early switch. So like before a couple of weeks or 2 to 4 weeks of starting the medication, unless somebody is not able to tolerate the medications for a side effect. So the first step always is to optimize the dose. If you're not feeling better, is there room to move up and you're not having side effects or enough side effects to stop the medication? Are we taking our medications? Are there other medications that we're taking that are potentially preventing this one from working? And so these are things to look at carefully with your family doctor and your psychiatrist. Can we add on a medication or add on some psychotherapy or some behavioral interventions to try and really pull out some more response for people? And then we look at when exactly to switch and when to add on a medication. I won't go through these, but these are good to have for you. So here's our big complicated algorithm of what we do and when we should change or add on or switch medications. And again, we won't go through this again, but you do see down here that we consider always this sort of risk factor for recurrence or for people to become unwell again if they have a remission from their symptoms, if their symptoms have gone away. So these are some of the medication options that we look at. Green is our first line, and these are medications that we would add on first for people who have not gotten improvement or have gotten some improvement but still have symptoms going on, that we can try and add on some medications to get them better. The next question I'd like to discuss is one that's near and dear to me. It's the focus of my research, and it's something called treatment-resistant depression. How do we know if people have treatment-resistant depression? So treatment-resistant depression is a term that's been around for a long time, and it's most commonly used when we talk about depression that has not responded to at least 2 different interventions, whether that's psychotherapy and medication, or 2 different types or classes of medication, or other types of interventions that we'll talk about in a minute. But it's not a great term because a lot of people feel like there's something they have done wrong to be diagnosed with something called treatment-resistant depression. So we've been trying out some other terms. I don't think we've landed on the best one. There are some discussions about using what we call using the term difficult to treat depression. So it's not that anyone has done anything wrong. It's not that there's something wrong with them. It's the depression that's wrong, right? And it's on us, the physicians and the therapists and the clinicians, to try and figure out what is not being treated and what we have had difficulty treating, the people who are helping to treat our patients, not our patients themselves. There's also the term refractory depression. So it's not responding to medication or to treatments. And we have lots of different staging models. So there are models from definitions from the US and from Europe and from Australia to how we can define what we call treatment-resistant depression. I'm going to use this term today because it's the most commonly used one, and we abbreviate it by saying TRD. So again, a topic that is close to my heart because it's the clinical work I do and the research that I do, the options besides antidepressant medications. And of course, we're not discounting the psychotherapy that we heard about this morning, but because that has been covered by people who are more expert than me, I'm not going to mention it so much here today. So some of the options are things like brain stimulation, and these are things that we offer within the Depression Center, as well as these comprehensive medication assessments, recommendations, and brief follow-up. rTMS is a non-invasive type of treatment that uses magnets to activate or quiet down specific areas of the brain. And there are people who are more likely to benefit from this treatment called rTMS or less likely to benefit from the treatment. And just for the sake of time, we won't go through this here. But if you are interested in this treatment, it's a safe treatment that's been around since the mid-1990s. It is something that you would have to come into clinic to have on a daily basis for a few weeks. But again, we don't have a catchment area within the Depression Center, so anyone from around Ontario, we would be happy to treat with rTMS as long as they meet the criteria for safety. And you heard a bit about that from a question earlier. And so this is a newer type of rTMS that actually, instead of taking about 40 minutes, this type of treatment called theta burst stimulation takes 3 minutes. So people come, they have their 3-minute treatment, and they go back to work or school or back to their family for the rest of the day. And it's not so difficult to tolerate. You may have heard in the news about something called the SAINT protocol that has come out of Stanford, where people have multiple treatments in a day, up to 10 treatments of rTMS in a day. And instead of coming for several weeks for treatment, they actually come for 5 days and they get multiple treatments in a day. We are not offering this right now at the Depression Center. It's something that's still investigational, but we are looking to explore it a little bit more. And initially, when rTMS came out, there were some questions about who it would be effective for. But this study from last year or 2 years ago shows that rTMS and the different types of rTMS are actually effective for people of all ages with depression, older adults, as well as people in their adult life range. You may have heard about electroconvulsive therapy or ECT. This is also on offer at the Depression Center, but it is really, it's an invasive treatment. It's reserved for people who are really quite unwell and for whom other options have not worked. We also have some research studies right now going on exploring ketamine, and ketamine we know so far has been shown to be efficacious, so to work in these sort of single infusion studies. So a few treatments over several days, and the treatments seem to work quite well. And so we're exploring this both for bipolar and unipolar major depressive disorder. And then we also have some studies going on looking at psilocybin, which is a hot topic right now. People are accessing this active ingredient in magic mushrooms called psilocybin. We see early evidence that it may be effective for people who have what we call treatment-resistant depression, but there's lots of work yet to be done, and that's one of the things that we are exploring at the Depression Center. So I'm almost out of time, but I really wanted to touch on other types of depression, and I see that in the chat there are some questions about that here. So there are other types of depression aside from major depressive disorder and aside from these major depressive episodes. One of the others that you may be aware of is something called bipolar depression. We talk about bipolar disorder. We talk about people having experiences both on the depressive end of the spectrum, but also on what we call the manic or hypomanic end of the spectrum, where people are more activated, they can do risky things, act out of character, sometimes have magical thinking, really be sped up. And bipolar depression is sometimes treated differently from unipolar depression. So here are some of the things that we look at when we talk about treating bipolar depression. So we talk about people's current experience and the symptoms they're having, the medications they're on, about whether the treatments that they were having before have been working and what they've been experiencing there. And then again, we go through adding or switching medications and adding on sometimes also psychotherapy or other psychosocial treatments. And these are some terminologies that you may hear. So frequently in the treatment of either bipolar depression or bipolar mania, we talk about using something called a mood stabilizer medication or atypical antipsychotic medication. We also use medications like Epival or Develprox. Those are the same medication, and I've put the other names for it here because it's referred to by multiple different names. These two items are relevant outside of bipolar depression, but just to define them here, when we talk about a recurrence, because bipolar disorder includes multiple episodes of these symptoms, it means a new episode or new symptoms that have come back after somebody has gotten better. And maintenance treatment, similar to in major depressive disorder, includes things like ongoing treatment to prevent or to prophylactically stop any recurrence of symptoms. So you can see this complicated chart here looking at all the different levels of evidence for the different phases of bipolar disorder here and some of the different options. And again, for simplicity, we won't go through this now. But important things to think about when we talk about prescribing medications for bipolar depression: what people have responded to before or not responded to before, what side effects that were intolerable, or what adverse effects people may have had with different medications. These are some of the most common medications that we use and some of our most effective for bipolar depression. Lithium, which has been around for a very long time, lamotrigine, which you may have heard something called Lamictal, and quetiapine, which is also called Seroquel. There's some things that we don't recommend in bipolar depression, and that is for somebody to be on an antidepressant without other medications on top of it, because it doesn't seem to work and it seems to push people into those hypomanic or manic episodes. If people have what we call a mixed episode, where they have both symptoms of depression and symptoms of mania or hypomania, these are some of the typical medications that we may use. And for people who have what we call rapid cycling bipolar disorder, so people who flip quickly from a depression to a hypomania or mania, these are some of the things that we would certainly do. So Lamictal or lamotrigine doesn't seem to work so much. We don't have great evidence for specific medications that work for rapid cycling over others, but certainly we would stop people's antidepressants and stop stimulant medication to prevent or try to minimize some of that flipping. So again, there are some principles in terms of adding on or switching medications, and this is how we make sure to try and get people better quickly if things are very severe. So we use some of these medications, quetiapine or lurasidone, to try and help people very quickly. Medications like lamotrigine, which you have to start and stop very slowly, are not great to use if somebody needs to get better quickly. And this is where something like ECT might be considered if somebody was in grave danger. There's some evidence for rTMS for bipolar depression. The problem is we don't know which type of rTMS is better than others, and that's something that we are starting a study on at the Depression Center within the next few months. So if you are somebody who has been diagnosed with bipolar depression and you have tried lots of medications and they haven't worked, and you would be interested in brain stimulation like rTMS, certainly try to access a referral to our center and we'd be happy to see you. I'm going to just go through this a little bit quickly because I want to get on to the other types of depression. So this is some information about an illness called depression with psychotic features. And this is where somebody has a low mood, but they also have this experience of things like strange beliefs, paranoid beliefs, or auditory or visual hallucinations. And we know that in this illness, the best treatment option is the combination of an antidepressant and an antipsychotic medication. And so this is just some research showing who gets better and who gets better more with different types of treatments. I saw a question in the chat, and I want to focus on it in a second, but just to put up here the issue of persistent depressive disorder. So persistent depressive disorder used to be called dysthymia, and it is sort of this depressed mood for most of the day, but less severe than a major depressive disorder, and less effect on your day-to-day life. So people with dysthymia or PDD usually have functional relationships. They can go through school and through work and get married and have children and all of these different big life events, but they really are not experiencing as much joy, as much reward, and as much pleasure or a good mood as other people may. And so we know also that usually this is present for more than 2 years at a time. We also know that antidepressants are usually effective in some way, but that we have to look at what we call a chronic disease management approach. So being diagnosed with PDD is similar to being diagnosed with type 1 diabetes. You will likely have to be on some sort of medication in some way, but there are things that you can do as well, and the people around you can do to support you to help your life to be better and to help your health to be better. And that is focusing on improving your quality of life and your functioning in life through things like sleep hygiene, exercise, behavioral activation, and other aspects like that. So just in our very last minute, there are always new things on the horizon in psychiatry and in the treatment of mood disorders. We're never at the end of the road. And some of the things that are being explored are things like more research into psychedelics like psilocybin and other medications, anti-inflammatory medications, things we call glutamatergic agents, so acting on different parts of the brain than previously explored. And just make sure we covered very quickly. I know I talked fast, so I apologize. But so we talked about different types of depression and treatments. We talked about the evidence base for different medications for major depressive disorder. We talked about treatment-resistant depression or difficult to treat depression. And we talked a bit about some of the research going on in our center with some of our novel on the horizon treatment options like rTMS, which has been around for a while but continues to evolve, psilocybin, ketamine, and some of the newer options coming out. And I'll just say thank you. And then I'll stop sharing.